Hey everyone, and welcome. If you're a trainee in medicine, especially GI, you know that esophageal symptoms can be a real diagnostic headache. Today, we're going to cut through the confusion. We're breaking down the ACG clinical guidelines to give you a super clear roadmap for esophageal physiologic testing, so you can pick the right test for the right patient every single time.
So here's our game plan. First, we'll talk about why just scoping a patient isn't the full story. Then, we're going to walk through 3 major clinical pathways: what to do for obstructive symptoms like dysphagia, how to handle typical reflux, and then how to tackle those really tricky atypical symptoms. We'll wrap it all up with a clear, actionable playbook you can literally start using tomorrow.
All right, let's set the stage. You've got a patient with symptoms that just won't quit. You do the endoscopy, the initial workup looks totally normal, but the patient is still miserable. This is the exact moment, that clinical crossroads, where physiologic testing becomes absolutely essential.
Let's make this real. Picture this classic scenario. A patient comes to you complaining of dysphagia. They feel like food is getting stuck. So you do the right thing, you take them for an upper endoscopy to look for a structural cause, and nothing. It's totally clean. No rings, no strictures, biopsies are negative. So what do you do now? This is precisely why we have to go beyond just looking at the anatomy.
And that's where esophageal physiologic testing comes into play. You see, these tests aren't about anatomy, they're all about physiology. They're designed to tell us how the esophagus is actually working. We're moving from just a visual inspection to a real functional assessment.
Okay, so this is our roadmap for the whole explainer. Think of this algorithm as your North Star. After you've done that initial scope, the patient's main complaint, whether it's obstructive, reflux, or something more atypical, is going to send you down one of these specific diagnostic pathways. Let's break down each one.
Let's start with that patient who feels like something's stuck. We are officially on the obstructive pathway, digging into symptoms of dysphagia and regurgitation.
Now, we all use symptom questionnaires, right? They're great for tracking how a patient is feeling over time. But, and this is a big but, the guidelines are super clear. For making a diagnosis, their utility is pretty limited. I mean, with sensitivity and specificity that low for major motor disorders, you just can't rely on symptoms alone to figure out what's really going on.
And that is exactly why we need an objective test, which brings us to high-resolution manometry, or HRM. This is, without a doubt, the gold standard. Instead of just a few pressure sensors, HRM uses a catheter packed with them. It creates this beautiful, detailed pressure map, a topography of the entire esophagus during a swallow. It's a total game-changer compared to the old way.
Just look at the difference here. The old conventional manometry gave us these simple, squiggly line tracings. HRM gives us a full color map. This means we're much better at diagnosing conditions like achalasia, and, just as important, 2 different doctors are much more likely to agree on the reading. But here's the real kicker for patient care. HRM lets us subtype achalasia, and that subtype directly tells us how well a patient is going to respond to certain treatments. That is a massive clinical advantage.
And we can actually make our HRM studies even more powerful. By adding a few simple provocative maneuvers, we get so much more data. For instance, multiple rapid swallows can test something called contraction reserve, which helps us predict who might get dysphagia after anti-reflux surgery. A rapid drink challenge can unmask a subtle obstruction at the bottom of the esophagus, and giving a test meal can actually reproduce the patient's symptoms right there in the lab, which can really boost your diagnostic yield.
Okay, but what about those really tough cases? The HRM is kind of borderline, but your clinical gut is screaming that there's an obstruction. The patient's story just doesn't quite line up with the manometry report. What else have we got in our toolbox?
This is the perfect time to think about the functional lumen imaging probe, or FLIP. So while manometry measures pressure, FLIP measures distensibility, basically how well the esophagus can stretch open. It gives you a totally different but complementary piece of the puzzle. It's incredibly useful for nailing down an obstruction when the manometry is equivocal.
Okay, let's shift gears and jump to our next pathway. We're now tackling what is probably one of the most common things you'll see in clinic: patients with typical reflux symptoms like heartburn and chest pain.
I want you to just look at this number for a second. 54%. Just let that sink in. And here's why that number is so important. We've all done it, the PPI test. Patient has heartburn, you write for a PPI, they feel better, diagnosis, GERD, right? Well, look at the data. A big meta-analysis shows that while the sensitivity isn't bad, the specificity is only 54%. That is barely better than a coin toss. It means a huge number of patients who feel better on PPIs don't actually have pathologic reflux when you test them objectively.
So this leads to a super common question.
When we do reflux monitoring, should the patient be on or off their PPI? The guidelines give us a really clear strategy. If you don't have objective proof of GERD yet, you have to test them off their medicine. You need to establish that diagnosis once and for all. But if you already know they have GERD, maybe from a prior scope showing bad esophagitis, and their symptoms are sticking around, then you test them on their medicine to see if breakthrough reflux is the problem.
So when you finally get that reflux monitoring report back, what are the golden nuggets you're looking for? Well, these are the key metrics that tell you who's going to get better with treatment, especially before you think about surgery. An acid exposure time, or AET, over 6% is pathologic. A positive reflux symptom association is huge. It directly links their feeling to a reflux event. And a newer metric, low mean nocturnal baseline impedance, or MNBI, also strongly predicts a great response to therapy. All right, let's dive into our third and, honestly, most challenging pathway, the atypical and extraesophageal symptoms. This is where the link to the esophagus can be a lot less obvious. We're talking about things like chronic cough, hoarseness, and that really bothersome belching.
You know, symptoms like hoarseness often get blamed on laryngopharyngeal reflux, or LPR, based on what an ENT sees on laryngoscopy. But the evidence for that is actually pretty weak, the diagnostic accuracy of only 44%. That's why the guidelines strongly push for pH impedance monitoring to get an objective diagnosis before you label someone with LPR.
And remember, not everything that comes up is reflux. You have to keep these two behavioral mimics on your radar: rumination syndrome and supergastric belching. Rumination is this effortless regurgitation of food, and you can confirm it with manometry. Supergastric belching is more of a learned habit of swallowing and expelling air, which you can nail down with impedance monitoring.
Okay, we have covered a ton of ground. So let's boil it all down into a final, rapid-fire clinical playbook. These are your key take-home messages.
Play number 1. This is non-negotiable. If you are even thinking about sending a patient for anti-reflux surgery, you absolutely must get a high-resolution manometry first. The symptoms of GERD and achalasia can look identical, and doing a fundoplication on a patient with undiagnosed achalasia would be a clinical disaster. And for play number 2, when you're working up dysphagia, be specific with your radiology order. A standard barium swallow just isn't good enough. The guidelines recommend a timed, upright barium esophagram, and, this is the crucial part, adding a 13mm barium tablet. This standardized approach is way better at assessing how a solid bolus moves and for picking up those subtle obstructions.
So there you have it. We've walked through the whole diagnostic algorithm, from obstruction to reflux to all those atypical symptoms. We've seen how to choose the right test for the right clinical question. So the question I'll leave you with is this. The next time a patient with persistent esophageal symptoms and a normal scope is on your schedule, how are you going to put this playbook into action?